Do your clients seek your support prior to birth? How about during pregnancy or after birth? Do they feel comfortable going to see someone else for help and then returning? In today's episode, I talk with Holly Tanner, the Director of Education at Herman and Wallace Pelvic Rehab Institute, about the support we can offer clients in their healing and life journey. Hello, friends. This is Lynn Schulte, and you are listening to the Birth Healing Summit podcast. We are here for meaningful conversations that will transform the way you work with pregnant and postpartum clients. Whether it is a new perspective, tool, or technique, you'll be able to implement it into your practice today. I invite you to sit back, listen with an open mind, and grab the golden nugget today's guest has to offer. Now let's get started. Welcome everybody to this episode. We are so blessed to have with us today Holly Tanner. Holly is a physical therapist. She has a clinical practice in Seattle, Washington. She's also the Director of Education for Herman and Wallace, a Pelvic Rehab Institute, and she is just a gem. And I'm so blessed to have you here. Thank you for being on this podcast, Holly.
Thank you, and thanks for all that you've done and will continue to do in this field.
Thank you. Well, today you and I are going to have a conversation, and a really fun one, I can tell from before we hit this record button. We're going to be talking about the supportive journey. What do we mean by this, Holly?
Sure. Well, I think when we think about the peripartum period, there's so many uh, simple go-to topics. We can talk about the abdominal wall, we can talk about continence, we can talk about the natural occurrences of hip pain or issues from fluid management like carpal tunnel. Like those are all really meaty and so useful. And I think we tend to get excited when we're teaching it, whether in the clinic or to other colleagues or working with folks, because it's so treatable. These conditions have such an impact on someone's quality of life, and yet sometimes very simple strategies, including education, are the piece that really are the light bulb. Or again, even supporting folks through that pregnancy period when we know that so many times they're going to feel so much better once they get on the other side of birth, right?
Right.
And
Once they have that baby.
right. And so that's good work, right? That is such important work. And when I tend to think about where I've progressed in terms of the patients that I care for now, it's a lot of chronic pain. And it's my favorite. I love looking at people and saying, we're going to stick this out. Like your pain doesn't scare me at all, right?
God
And
bless you, Holly. That's
because
awesome.
they're often met with such intimidation, maybe apathy, maybe even frustration and anger on the part of their providers. But even well-meaning providers can end up dismissing someone with chronic pain because either they think, I feel like I'm doing the same things and we're not getting where I think you should be, or this is hard.
Yeah.
It is. It
Yeah.
is hard to look at people and say, I know it's visit 7 and you haven't had much progress. Here's what I'm noticing objectively. Let's move forward. And so when I have attracted a lot of those patients with really severe chronic pain, the ones who some colleagues, perhaps with a bit less experience, would say, gosh, we've done a lot of good work together. I'd like to get another pair of eyes and hands on you. Go see Holly or someone again who's been around the block for a little bit. And the patients that I love to work with are the ones who come in and say, oh, childbirth? Yeah, I'd love to get there in my life, but we can't even have sex because this pain is so terrible. And all of a sudden, it becomes this incredible challenge of how do you get someone, first of all, to enjoy where they're at in life currently and to enjoy their relationship by meeting the goals that they want around sexual health and reproductive health.
Yeah.
And so many times, as you know, it's met with this tremendous amount of fear. Like, okay, but what if I do get pregnant? Is my pain going to be worse? How am I going to feel? And then will my childbirth be terrible? And then, oh, good heavens, if I'm having pain now, what is it going to look like on the other side? And I love holding space for that journey.
Yeah. Oh, and that is quite the journey, right? To take them from not even think it's a possibility to being able to get there and beyond. So I'm curious, Holly, what do you find like I know we need to meet every patient where they're at, But do you find with these chronic pain patients that you're working with, does there seem to be any similarities that you find in their journey?
Sure. And I would have to say that that I need to acknowledge a bias, right? Because so many times I often think about this. I'm right in the heart of Seattle.
Mhm.
I'm working in a place where a lot of the folks immediately surrounding me have access to insurance and also a plethora of diverse providers. And so when someone comes in to see me, oftentimes they've got their yoga class, they have their chiropractor, they have their Feldenkrais practitioner, they have their naturopath. They have access to really good teams of people. And again, I'm tending to work with folks who do have resources in terms of access to insurance or financial means to even do some cash pay. That's a very different demographic than
Yes.
in some other locations. So I have to first acknowledge that. Therefore, when people come to see me, they have a bit of a been there, done that approach.
Mm.
And when we engage with some of the manual therapy pieces, one thing I will often hear from them is, oh, nobody did it quite like that. Nobody pushed that hard. Nobody engaged the pain like that,
Mhm.
And so that is one piece that I've seen. And then I think another is simply throwing out all those little pieces that you pick up when you've been doing this for a while and get to learn from our patients and from other providers and with each other. Of course, even when we teach, right? We're
Yeah.
always learning so much. And so we can just rattle off in our heads. Have you had this scan? Has anyone talked to you about this yet? Have you tried that cream? Has anyone looked at that ankle? You said it's been a source of dysfunction for a long time. And so I think what's really nice is being able to hold all those pieces to sort of rattle through ideas and options, and then really to, like you said, meet the patient where they're at. Because one thing that I've learned that's very helpful is non-attachment, right? I'm
Yes.
not attached to it, whether or not they want to see me. Of
Yeah.
course, my ego loves it when they're like, I'm so glad I found you. This is so great. Of course, my
Yes.
ego loves that. I'm human.
Yeah.
Um, but also, if they go, I kind of feel like I need to go do this, I say, okay, well, here's the thing. I'll be here. If
Yeah.
you want to go do that and then circle back with me, you're welcome to. You let me know what you need from me. And
Yeah.
I think that, in terms of what I find is also just a truth in that sometimes they might want to go do Botox. Okay,
Mhm.
I'll be here. They
Right.
might want to go have some imaging done. They might want to try another physical therapist who does a lot of focus on a lot of exercise training or repatterning and things like that. I say, awesome, great. I hope that's super helpful. If you want to pair that with what we're doing or not, you just let me know.
Right. Right. Yeah.
But I
Um,
will also say, and this, pardon my interruption, this feeds into what we're going to be talking about at the summit. I also do find that there is a lovely and appropriate vulvovaginal focus
mhm.
when we're talking about, the childbearing years and such. But that anorectal piece sometimes is maybe where things started. Maybe they had a terrible hemorrhoid or fissure or fall on their tailbone. And
Yeah.
so, well, I've got an SI belt and I'm doing some stabilization and I had a little bit of internal vaginal. But it's when sometimes you go to the anorectal canal or in that more posterior area, that's what I find sometimes is the piece that really unlocks the rest of that tension and pain and allows for more movement.
That's cool. And you and I are going to dive into that more in the Birth Healing Summit, everybody. So please make sure you check out Holly's interview. Peripartum Health is the title of your talk. So I'm super excited to for us to dive into that. And Holly, I totally have to agree that anal rectal area, the intra rectal I'm sorry, the intra oh god,
Ischiorectal,
pardon?
ischiorectal fossa?
Thank you.
Yeah.
Thank you. That's our Nicole Cozine mentioned that in a podcast once. And y- okay, please excuse, I'm gonna out myself here. That wasn't on my radar. Do you know, like when we learn all the different anatomy and pieces, like you don't learn everything. And I just that had like fallen off my radar until she said something in a podcast. That is so critical in assessing that, especially I find when that levator ani muscle isn't able to function as well, maybe it does on one side, but not the other. And you go assess that and it's like, oh, that's restricted. That doesn't move as easily as the other side. And when you go in and work with it to try to bring that balance to it, it's amazing what it does to the levator ani muscle function.
Mhm. And in the way that a lot of patients don't necessarily understand the totality of what we offer,
Yeah.
and in the way that they don't think things are connected, or they just forgot. So many
Uh-huh.
times, if you assess that area, they'll say, "Oh, that's right. I had the
I had
hemorrhoid
that fall.
banding. Yeah, I had that thing that didn't go so well and plagued me for a long time, and I've just lived with it."
Yeah.
And the other piece that I find that they say so often is when we're working a little bit more in that anal triangle, they'll say, "Oh, I feel that all the way to my pubic bone." And they get up and they kind of wag their tail and say, "Ooh, that's different."
Yeah.
And that's nice because then to them it signals there's a shift. There's something a little bit different. It's a change in sensation. Maybe it's that brain connecting to, "Oh, that's what it feels like when it's not so tight," you
Right.
know?
Restricted and yes, absolutely. I love that. And so it's not and everything is so connected, as
Mhm.
we know. And I think another big piece too, if we're talking intravaginal work, we're talking that anorectal area. I also found the anterior wall, the anterior vaginal wall and working with the urethra and the bladder, the fascia there, that is so critical for health. And then also the cervical mobility and making
Mhm.
sure that the cervix has good mobility in there too, like all that. It just everything needs to move freely in there, and a lot of times it's not when
Mhm.
our clients are having problems.
Right.
So, cool.
Well, and I feel like our profession has grown up so much to
Mhm.
the extent that now we just are revising the whole series. And in the pelvic function one class, someone said like, "Wow, this is a lot. Like this is some up-leveled material." But that's because there's more access to this information. People are coming into the profession now knowing about the pelvic muscles and intra-abdominal pressure and all these wonderful concepts. So we don't have to start with some of those basics. We get to elaborate and offer more. And what's cool is, as you're talking about some of these other techniques and things to consider, now we keep pulling things from what we might consider intermediate advanced, and we're feeding that earlier on. So I think it allows us to have more of those discussions about really complex issues like venous congestion or some of those things where we all just throw up our hands and say, "Ooh, this is tough."
Yeah, yeah. Well, and there are a lot of really tough, what's the right word? Problems
Mhm. Yeah.
in this area. I mean, it's a really I'll never forget, I, offer cadaver labs here, and I teach out of my house in Longmont, and there is a cadaver lab in downtown Longmont, so it's just, like, 10 minutes from my house, and I always set up, whenever I'm teaching, to add in a cadaver lab if people wanna go to that. I'll never forget, like, the space in the pelvis is, like, this big, like, your fist fits in there, and to think of the bladder, uterus, bowel, and everything that fits in there is just and all those structures expand and contract,
Mhm.
expand and contract. It's not a static area, and
Right.
so there's got to be mobility. And I think we're really the only profession that really looks at mobility of things. Like doctors don't understand, I don't feel scar tissue, restrictions, things like that. At least I don't, are your doctors out there in Seattle more?
Well, we're blessed to have a lot of naturopaths as well, and so I find a lot of them are trained in visceral manipulation and techniques like that.
Yeah, but and I also I thank you for clarifying your practice. I'm in a very similar situation, a very resourced area, especially with a cash practice. I have a friend who is working out of the hospital and working with a lot of Medicaid, Medicare type clients, and the amount of um I'm just gonna say trauma that they've experienced in their life and and are currently living in is so challenging that
Absolutely.
I think a new grad working in that environment is gotta I just am in awe, and I think that's probably the most challenging position to be working with those types of clients. It's not your traditional stress incontinent client, right? It's not
Exactly.
just that. And
And when
so
you'd asked what maybe themes tend to show up with some of
yeah,
those really difficult, complex chronic pain cases, certainly trauma is in that. And from what you just described, it makes me think too about the trauma that providers that we experience from hearing those stories, from also feeling that
yeah,
frustration or maybe helplessness that we want to do more, offer more. And so I think when folks are working in environments in which folks are dealing with a lot more socioeconomic or, racial challenges, all of these burdens stacking up, um, we get to do, it has to be done differently. And I think the clinician also has to look at themselves and say, okay, I need to have enough to show up again tomorrow. And therefore, how can I preserve? How can I, look at what can this person take in today?
yeah,
What's going to be the most useful. And of course, that's what's so beautiful about all of these conversations about consent, about being curious, right? And looking at someone and saying, I have some ideas, and here they are. Do those match what your interests are? And I don't think that um, that kind of education, is that's not novel to newer practitioners, but it is to those of us who've been around for a while. And I just think I took my kiddo to urgent care recently, and the medical provider looked at him and said, "Are there any other names you use besides your first name?" Those simple little changes, I think, are so lovely, and you can see practitioners really working with that and trying and making these changes. And so I hope we can, if we get the financial piece of the healthcare system in the US better supported and all the other, socioeconomic, no big deal, just those.
just those
But
little
you know,
things.
I think of, whenever we can, creating that kinder, gentler healthcare experience, and but also being really honest about what providers and patients are up against.
Yeah, definitely. And I love what you said there, just, like offering our clients one little piece. Because sometimes someone who's dealing with so much in their life, that's really all they can handle. And it
Mhm.
may just be helping them to figure out how to breathe,
Right.
you
And
know?
the one thing, we could talk about this for hours, but I think when we're newer in the profession, we want the cookbook, we want the script, we want the list.
Yeah.
And struggling with nuance is something that hopefully a lot of clinicians are exposed to in their internships and in their early jobs, that there are times you have to look at someone and say, I'm feeling a little challenged here. I have some ideas, but I think we're just gonna have to see how you do, and I'll look forward to hearing what you're interested in working on next week with me, you know? And
Yeah.
and that, maybe that's not how we're taught to communicate with patients, but I think that kind of honesty can be really helpful because there, I had someone in here 2 weeks ago, and I looked at her and said, "Do you have some stretches that you really like and that feel good to you and that feel useful?" And she said, I was taught, I was taught child's pose and happy baby and this hip stretch. I said, are they working for you? And she said, no, I can't get into these positions because my hip hurts and then I can't quite do this. I said, no, I said, that is not your fault. I said, it is our job as the providers to say, have you been giving something that works for you? And if they say not quite, it's our job to look at them and say, okay, let's play with this.
Right.
Let's find something that really works. But again, if someone says like, but I gave them the exercises that were on the PowerPoint or on the handout,
Yeah.
and they said it was fine, that's not enough. We have to look at people and say, am I really meeting you where you're at? And if
Yeah.
not, again, we need to have the grace to look at them and say,
Yeah.
let's dialogue about that a little bit more.
Holly, what would you say to a new grad? or someone newer, or maybe someone trying these different exercises to know whether an exercise is actually appropriate for that client or not. Are there signs or things that we should be looking for or hearing our clients say when they do the exercise to know
Well,
we're not going down the right path?
sure. I like asking just those kind of open-ended questions or looking, seeking that honesty, and that could be anything from, how are you feeling about your progress? Like if someone said, hey, do you feel like you need to keep going to rehab? What would you say? And really let them tell you their story versus saying, well, what I was thinking is we could decrease to once every other week and then we'll plan for your discharge. It's like, well, ask the person where they're at, and also again, just like that conversation I had with the person, I said, like, do you have some stretches that feel good? And
Yes.
they go, well, yeah. Hmm. Do you want to show them to me? Or do you want to ask me some questions about those? Unless you get a real enthusiastic. Because if someone says to me, like, oh, yeah, I do yoga every morning. I went to, specific clinicians. I got that covered. Excellent. I'm going to
Oh,
believe you, trust you when you say that.
right. And sometimes someone who's really bendy, stretching is not exactly what they should be doing. So I love this question of what's working for you
Mhm.
and letting the client guide us. Um, and so I guess when someone's doing an exercise, do we do we know for sure if it's going to be helpful or not in that moment, or is it something that we just kind of have to kind of see and have them come back and report back to us? I guess
I
that
think I think allowing a little bit of time is really important because,
yeah,
and saying like, hey, last time you asked me to review those hip TheraBand exercises with you. Did you get a chance to try them? What do you think? You know
right.
what? They're kind of too easy. Okay. you know,
There we
or,
go. Yeah.
"Well, I didn't get a chance to do them. I feel like I need to try it again." Okay. Or, that's going really okay, but what I really want to do is get back to the overhead lifting class at the gym. And that's an opportunity for me. And this is an interesting challenge I think that clinicians can face too. If someone said to me, I want to do some overhead lifting, I'd look around my clinic space and say, I don't have that equipment. And I don't even, I don't have all that expertise, but you know what? I know people who do. So I'm constantly connecting people to clinicians who are either better than me or better set up for me, or if I just don't even want to do it, I'll go, I could do that, but I don't really want to. You want to see someone who wants to do it, you
It
know?
that is key, and I think as practitioners, we need to go where our hearts are and where our love is.
Yeah.
And I
But
am
what do
not
you do if you are the solo clinician in an outpatient setting at the hospital and the hospital says, we need those numbers to keep this department alive? Like I think that's where you get tricky. Or you're in an outpatient clinic and you're going to say to your boss, I referred him out to so and so because they've got better
okay.
clinicians than us.
True, true. I'm
It's
thinking for the
sticky.
solo practitioner
Yeah.
who is working for themselves,
Yeah.
then you have options, right? Then you have the ability to go down, like, follow your heart more. But you're
Mhm.
right. If you are in those situations, we do need to have all hats to
Mhm.
be able to
And I
approach
think
that.
if we can, as clinic owners, and I realize this may not always be accurate, but if we can come from that place of abundance, if someone says, hey, I've been working with this person, I'd like to send them to you to get that second pair of eyes. I'll say, well, can you come with them as the clinician?
Ah,
If I'll make an evening appointment with you or weekend, whatever works for you and your client, but I want them there because they're probably going to be going back to that person. And I'd like to have that conversation of, oh my gosh, that's great. That's excellent. Did you try this? No, what do you mean? Well, like that, and so if it's this
yeah.
collaboration, I mean, patients see that we care and we love working with them, but we also are supportive to each other in the community. And that I think is really critical, that it doesn't have to be, oh, well, you don't steal my patient. It's more like, let's help each other learn and share and grow because there really are enough of these patients for everyone.
My gosh, aren't there? For sure. For sure. Oh my gosh, this has been wonderful, Holly. Thank you so much for sharing all this. And everybody, I am super excited for Holly to share the anorectal peripartum health with us for the Birth Healing Summit. Any last word of wisdom that you would like to share before we say
Oh
goodbye?
gosh, I don't think so. I think just we have to keep looking to each other for that inspiration and support, because this is challenging and good work, but a lot of us are working on our own healing and growth the entire time.
Yeah.
And so if we can, keep working together and supporting each other, and again, learning from each other, it's really special.
Well, that's why I do these podcast episodes, because I love sharing information and learning, and not only with fellow PTs. I find from the summit, working with midwives and OTs and craniosacral therapists and just learning from all different disciplines, it really does open my eyes to way new things that as a PT I've never been exposed to. So I think interdisciplinary learning is critical as well. So thank you. Thank you so much for sharing, Holly. And we will see everybody on the next episode. Here's to smoother births and faster recoveries, everybody. Take care. Bye-bye. Today's podcast was brought to you by the Institute for Birth Healing. To discover more, visit instituteforbirthhealing.com. To claim $50 off of any online course, use coupon code podcast50 at checkout. Till next time, I'm Lynn Schulte, founder of the Institute for Birth Healing.